Hello and welcome to the Medical College of Wisconsin's Coffee Conversations with Scientists. I'm your host, Raina Andrews, and for those of you tuning in for the first time, let me introduce myself. I'm a mother, a children's book author, a public health advocate, a TEDx speaker, and an engaged community member. I am happy to return as your host of Coffee Conversations with Scientists for the 2024 season. And since 2021, we have been sharing the science behind today's most important health topics. Coffee Conversations is brought to you by the Advancing a Healthier Wisconsin Endowment, which is a statewide nonprofit working to improve health and advance health equity in Wisconsin. So today we have a very special show. Did you know that nearly 10% of babies in the US are born prematurely, and many of them face life-threatening complications like respiratory failure? With premature birth rates on the rise and these complications being among the leading causes of neonatal mortality, understanding their causes and treatments has never been more crucial. Today, we're speaking with Dr. Girija Ganesh Konduri. She's a pediatrician with Children's Wisconsin and professor at the Medical College of Wisconsin on how experts are working to give these vulnerable infants the best chance of survival. Welcome, Dr. Konduri.
Yeah, thank you very much, Reena. I'm very glad to be here, and thank you for this opportunity.
Absolutely. Now, folks out there listening and tuning in, we will be covering a great list of questions regarding these premature ailments, is specifically respiratory distress syndrome and respiratory failure. So we have a lot to cover in a short coffee break. However, be sure to note your questions right in the chat function of our live stream so we can get to as many as possible. So Dr. Konduri, let's get to it. Let's start with a baseline of information for our audience to really wrap their heads around the significance of what we're talking about today. So can you start by explaining what we mean by premature birth and why prematurity often leads to life-threatening complications like respiratory failure?
Yes, absolutely. Just to set the table, I want to mention that we measure the length of pregnancy in weeks, not months. And so human pregnancy is about 40 weeks long. And it has a range of 38 to 42 weeks because there is always some biological variation. So when a baby is born during that 4-week window of time, we consider that a full-term birth. But if a mom goes into labor and delivers a baby earlier than 37 weeks of gestation, that is a premature birth. And those babies are more likely to encounter difficulties because they haven't had the time to prepare their systems for this momentous occasion of being born outside their mothers. And within that first minute, they have to establish independence.
Wow. Now, do you have an image where you can help us illustrate
Yes.
this?
Yep. I'm going to screen share. And if I can, I think,
Yep, just go back to.
okay. Okay. So we're here. So throughout pregnancy, the baby is inside the mother's womb, being supported by placenta across the umbilical cord. And one of the most important organs that the baby prepares for being independent outside the mother is the baby's lungs. And these lungs in the baby are, when they're inside the mom, they're filled with a fluid, and that fluid nourishes the lungs and also gradually expands them. And we know that we're air-breathing creatures. So when the baby comes out and takes the first breath, then air has to enter the lung and displace the liquid, from the lung. And that transition happens within the first few seconds of, being outside the mother. But the preparation for this birth actually starts about a month or so before the baby is actually born. And right around 34 weeks of gestation, the baby begins to reabsorb some of the water in the lung. And so in a full-term baby, there is less water in the lung compared to 32 or 34 weeks of gestation. And around the same time, the baby begins to secrete a complex chemical called surfactant into those tiny potential air sacs. And surfactant is a slippery substance that basically helps to reduce the surface active forces between air that's coming into the liquid filled lung and the liquid. So if you can imagine, a child adding soap to water before blowing bubbles, those bubbles kind of float around and they remain stable for a few minutes. And the surfactant does kind of a similar function. It stabilizes that interface between air and liquid, and it keeps those air spaces open, so it's easier for the baby to breathe. And just as air is entering these lungs, the blood vessels in the fetus, which are kind of narrow and clamped down, begin to open up. And as they open up, the entire blood supply coming from the heart begins to flow through those blood vessels around the air space. And both of these events have to happen exactly same time because that is necessary for oxygen to start flowing into the baby's bloodstream. And that establishes oxygen supply by the baby's lungs so that the baby can be then independent of the mother.
That's a really good depiction of respiratory failure. Can you help us understand what is respiratory distress syndrome and why is that important for us to know about?
Yeah, so respiratory distress syndrome can happen both in babies born at full term and also prematurely born infants. So this is a term that we use when a baby comes out and is struggling to breathe and often turns blue and needs our help. And so even babies born at full term can have respiratory distress because if they develop a pneumonia before they're born, we also know that 1 in 10 babies passes meconium, baby's first stool, before they're born. And if the baby aspirates that meconium into their lungs, then that leads to complications because air doesn't enter the lung and the blood vessels around those air spaces basically clamp down and that leads to increase in the blood pressure in the lungs. And this is a condition that we refer to as pulmonary hypertension. Back in the 1980s, when I was a medical student, this is a long time back, and also I was training in pediatrics, 1 in 2 babies with severe pulmonary hypertension used to die as a result of complications of this disease. And we were able to rescue 1 in 2 babies at that time by putting those babies on a type of heart-lung bypass machine. We call it ECMO, that's shown here. But to do that, we had to do complicated surgery on those babies, putting plastic tubes close to the heart and then circulating the blood through an artificial lung. So we spent a fair amount of time during the 90s to develop nitric oxide, which is the chemical that's released into the blood circulation in the lung to make those blood vessels open. And we learned that during that research. We developed nitric oxide inhalation as a therapy for this condition. And I had the privilege of leading one of the large international trials of inhaled nitric oxide. And we published those results in 2004, about 20 years ago. And in that study, we showed that babies who received this therapy, we were able to reduce their mortality risk to just 5%. So this is a dramatic tenfold improvement in the survival rates for these babies happened because of the introduction of this therapy. And now this therapy is available in every neonatal intensive care unit in North America. And so babies are benefiting from it. And we also learned that we rarely ever have to use that heart-lung bypass machine for these babies. So we use it less than 1 in 10 babies now with this condition.
That is impressive. So you said that respiratory distress syndrome can happen in full-term babies as well as premature infants.
That's right. So,
So oh, go ahead.
so premature babies are actually more likely to develop this condition because both of those transitions, removal of the lung liquid and introduction of surfactant into the lung, the babies don't have an opportunity to make those things happen, particularly if they're born before 34 weeks of gestation. And
Oh,
so
wow.
those babies have greater need for intensive care support. Typically, if those babies are struggling, we would put a breathing tube so that we can put the babies on ventilator to basically expand their lungs using pressurized air and also give them extra oxygen.
I feel like you already explained it, and I think my next two questions will go hand in hand. Like, why is respiratory failure such a common complication for premature infants, and what makes their lungs more vulnerable? Is it because they're not fully developed yet?
Yeah, that's correct. So their lungs are not fully developed because the lungs are essentially growing, throughout the time that the baby is inside the mother's womb, and
Mhm.
they continue to grow. as a child reaches teenage years. So it's one of those organs that takes a long time to fully develop. So if a baby is born at say 24 or 25 weeks of gestation, they're literally missing out on 3 months of lung
Wow.
development that would have happened when the baby is inside the mother's womb. And so we can support them by putting them on a ventilator or breathing machine, giving them extra oxygen. And also we learned that babies who are born that early forget to breathe because they haven't established control of breathing. And as an
They
interesting
haven't had
side note,
to.
for
Yeah.
those babies, we actually give them caffeine. Same thing that we are drinking every morning, because caffeine actually stimulates their breathing. And we learned through our research that giving them caffeine actually improves their long-term outcomes. So we have a number of treatments that we offer to those babies, but the basic problem that the lungs are not fully developed and they missed out on that lung development is still a long-term challenge for them because that um, uh, all the therapies that we use to support those babies can also injure the lungs, and those injured lungs don't grow as well as they should, as well as they would have if they stayed inside their mothers. And so that leads to a chronic long-term condition that we refer to as bronchopulmonary dysplasia or
Mhm.
BPD.
So I want to come back to that, but I definitely want to talk about the long-term effects of this. But in my opening statement, I talked about premature births being on the rise. I'm interested in understanding what are some of the disparities that exist and who is more predisposed to this syndrome because they're more predisposed to having a premature birth.
Yeah, great question. This is something that we need to address as a society. Prematurity, prematurity rates in general are on the rise as mothers are getting older when they're pregnant, and that increases the risk of underlying medical conditions like high blood pressure,
Mhm.
diabetes, and obesity. And these complications are linked to increased risk of premature birth. And there are also significant disparities. Black mothers and Native American mothers are 50% more likely to have a premature birth. And this is linked to a variety of factors. We know that 1 in 4 Black mothers or Native American mothers has no access to quality prenatal care. So conditions that are treatable, like high blood pressure or diabetes, they go untreated, and that increase the risk of preterm birth. And these moms also have limited access to nutritious diets that increase their risk of obesity, leading to additional complications. And there is also something that we need to address as a society, which is the social stress that they experience because of low income and limited transportation, violence in the neighborhoods. All of these factors have an immense impact on their stress level, which increases the risk of preterm birth.
Wow. So let's go back to your point right before this about long-term effects. If a child is affected by if a child is affected by premature birth and they end up developing some type of respiratory failure or respiratory distress syndrome, what are some of the long-term effects on that child?
Yeah. It's an important question that we should talk about. We are getting better at rescuing and saving these premature babies. And babies that are most at risk for this long-term complication that I referred to, BPD, are those babies that are born at less than 30 weeks of gestation. And so today we're able to rescue babies that are born as early as 22 or 23 weeks of gestation. Imagine that's just about half the length of a human pregnancy. Uh,
Mhm.
But the earlier they're born, the less developed their lungs are, and more likely they're to develop this long-term complication called BPD. And BPD is a term that we use. Essentially, the underlying substrate for that is that these underdeveloped lungs, when we expose them to ventilator care or extra oxygen, they get injured, and then the lungs stop growing. And when the lungs don't grow, then that imposes significant limitations, for that baby and for that child as the child is growing up. And that can lead to increased symptoms such as wheezing, exercise limitations, and and that can last a lifetime. And so that's why it's important to recognize this complication and treat it effectively.
I wonder, how does RSV affect children, child respiratory failure?
Yeah, it's a very important question and something that we need to prevent. So RSV is one of the respiratory viruses, and starting next month, this is our winter viral season, and
Mhm.
it's one of the three major winter viral pathogens. Fortunately, we have strategies to prevent RSV infection from setting in. Premature babies, when they develop RSV viral infection, that can put their life in danger. So those babies can literally stop breathing and go into full cardiopulmonary arrest or a code situation. And short of that, they can also develop rapid breathing and respiratory distress and get very ill and make trips to emergency room or to the hospital. And so this is something that we need to prevent premature infants from developing. So mothers can get RSV vaccine between 32 and 36 weeks of pregnancy. It's being offered. And if a mom previously received RSV vaccine, they don't need to repeat it in the current pregnancy. But every mother in that window of time should get the RSV vaccine because that stimulates production of antibodies against this virus in the mother that she can then pass on to the baby. And that would help protect the baby in the first 6 months of their life. And if a baby is born prematurely, before a mom had the opportunity to get this vaccine, let's say before 32 weeks of gestation, for those premature babies, as we take care of them in the intensive care unit, we can give them what we call as RSV immunoglobulin, and that's an antibody that we can give to the baby that would then protect the baby during the first few months of life. So we can start that vaccine while they're in the unit before they go home, and the pediatricians can continue to give those doses on a monthly basis. So we can
Wow.
we can prevent the infection from setting in the baby, and we'll also encourage the parents when they take the baby home to prevent these exposures by keeping other sick children away from the premature baby.
That's so good to know. Is this something that the patient would have to advocate for? Or is it something automatically given to the child?
It'll be given to the child. We always take a mother's permission, the parents' permission, but
Mhm.
but each newborn intensive care unit that takes care of premature infants has access to this RSV immunoglobulin, and we're actually going to start this at Children's Wisconsin on October 1st because we're just marching into the colder part of the year.
It's great timing. So now we're going to turn it over to our audience, Dr. Konduri. The first question is, does the preparedness of care for premature babies vary by hospital? Are the innovations you're describing widely available to all patients?
They're widely available, fortunately. The two medications that I referred to are the three medications: surfactant, inhaled nitric oxide, and also caffeine to stimulate their breathing. They're available to any level 3 newborn intensive care unit within North America. And so you can feel confident that if your baby is born prematurely and is taken care of in one of those hospitals, that baby would receive those innovative treatments.
Mhm. Another question is how soon after birth do these respiratory issues typically emerge, and what are the first signs that healthcare providers look for?
Yeah, these symptoms can start right at birth. So that's why it's important for a mom, particularly a mom going into preterm labor, deliver the baby at an established perinatal center. And these perinatal centers are linked to these level 3 newborn intensive care units. And the Children's Wisconsin is a great example. We have a perinatal center at Frederick Lutheran Memorial Hospital right here in Milwaukee location. And our newborn intensive care unit is right next door to the labor and delivery and perinatal center. So our experienced team will be present at the time of delivery for that premature baby, and we would provide that care right from the start. So the babies can develop respiratory distress anytime within the first 2 days of life. Sometimes they start out looking okay, but gradually over the next 12 to 24 hours, they start having more and more symptoms. And that's when we intervene by supporting the child to the extent that the baby needs.
Mhm. What resources are available to expecting parents to help them prepare for a situation where their baby would deal with this issue, or have these care needs?
Yeah, it's important for the mother to talk to their obstetric provider or family practice provider or nurse midwife, whoever is taking care of the mother, to ask these questions. If my baby is born and has these complications, can the pediatricians and the newborn intensive care specialist, and by the way, I'm a newborn intensive care specialist, are they available, to take care of the baby? And if it is an unexpected complication, if the baby is being born at full term, but these complications happen, what would be the plan? And so that is a discussion that's important to have with the physician taking care of the mother.
Another question from our audience is that you mentioned before ventilators and oxygen therapy and treating some of these babies in these cases. What are some of the risks or challenges that come with these interventions?
It's a very important point. So a premature lung is more vulnerable to injury to anything we do to support that baby. So um, the simplest thing we do is give extra oxygen. We breathe normally 21% oxygen, and we can give those babies anywhere from that concentration up to 100% oxygen to support the baby's life. And but that extra oxygen also has the tendency to injure the lung. And when we use ventilators to give airflow with under pressure, that can also injure the lungs. So we basically titrated, to the lowest level that the premature baby would need. And we have excellent monitoring strategies now, monitoring tools. So we use pulse oximeters continuously. We also look at the carbon dioxide levels in the baby using a skin probe or doing the blood test. And so we will titrate it to the lowest level. Uh, Nevertheless, when the babies are exposed to it, they will get some lung injury. And that's the goals of our future research. We're doing studies right now in the lab and at the bedside to understand some of the things that we can do to preserve the lung growth, given that some lung injury is going to happen.
That's another question I want to ask you, but I'm curious before we jump into that, what are some symptoms of lung injury? Like, how could someone know that their child is experiencing some type of lung injury?
Yeah. So babies will tell us that by gradually increasing the need for more and more oxygen, because as the lung gets injured, there will be more fluid that builds up more inflammation or irritation in the lung. And so that would actually increase their needs for support. And babies also start, breathing harder. And we see the evidence of this inflammation on the chest X-ray. So we often do chest X-rays, portable X-rays at the bedside in these babies, and we can see some of these changes on the X-ray. So collectively, when we look at these signs, we will then take measures to help those babies. Strategies to, move some of the water out of the lungs, and if necessary, we will give antibiotics if we suspect that infection is setting in the lung. And we can also give medications to decrease that inflammation.
We have time for two more questions, and I do want to return to your good point that you started down regarding research. Can you discuss some of the key areas of research currently underway to improve outcomes for premature infants with respiratory issues?
Yeah, we are very focused on improving the outcomes for babies with our bronchopulmonary dysplasia. Essentially a complication of premature birth, and that premature lung not being able to grow. We learned through our laboratory research. We look at throughout the gestation, the genes and gene networks that basically switch on and switch off at various points as the lung is developing inside the mother. And those studies are helping us understand how these gene networks get turned on and how we can turn them on if the lung is not doing it by itself.
Mm-hmm.
And so over the last 5 years, we have learned a great deal about some therapeutic agents that can turn on a number of these gene networks and restore the lung growth. And we're very excited about these findings. And we recently received a large grant from National Institutes of Health given to my lab from at Medical College of Wisconsin to basically take these therapeutic agents to the bedside. So we're close to launching those clinical studies next year. And so essentially, the goal is to then make the lungs grow again, given that some of this injury is going to continue and some of this is going to happen. And so, If we can help those babies grow their lungs, then we can ensure that the child would have long-term healthy outcome. So that's the goal of our research.
That's really helpful in helping us understand maybe what the future of this work looks like. And I think in closing for our families, and we have a lot of proactive parents out there, is
Yeah,
what advice do you have for parents whose babies are born prematurely and are dealing with these complications?
yeah. I would advise them to seek care and consultation at specialized centers like Children's Wisconsin. At Children's Wisconsin, we have a dedicated program to evaluate and take care of babies and children with bronchopulmonary dysplasia. We call it the BPD program. And we have a collection of specialists, newborn specialists, pulmonary medicine doctors, cardiologists, and hospital medicine and ICU doctors that work together as a team to evaluate these children. The lung has many different components to it. The lung has tubes that carry air into the lung, into those air spaces, and the air spaces that have to fill with air, and the blood vessels that I referred to around those air spaces that basically bring in the blood supply. And we know that each child with the bronchopulmonary dysplasia is a little bit different. Some babies have narrowing of those air tubes, and those symptoms tend to look more like asthma. And so we use different medications to treat that condition. If the blood vessels around those air spaces are squeezing down, pulmonary hypertension, we have different medications to treat that condition to basically sort out which factor is contributing more and customize the therapy for that child is very important. So that's why I would advise the parents to seek care at a specialized center like Children's Wisconsin.
That's very helpful, Dr. Konduri. And I know our audience likes to be informed, and we have a few resources for them. So, Dr. Konduri, we're going to put them in the chat, but do you mind sharing what these three resources are?
Yeah, I will share with you the email I sent yesterday to Michael.
Mhm.
I'm going to find it.
One is about the neonatal respiratory distress syndrome, if they want to read more about that.
Yep.
The other is the kidshealth.org. Do you want to share just a little bit about that website?
Yeah, I will. Uh,
And we also have
um,
the bronchial pulmonary dysplasia, which is more of a detailed article on the background of that disorder. And so these are some additional resources for our audience. If you want to learn more about some of the topics that we talked about today, we're linking them right here in the bottom. And with that, we're at time. Dr. Konduri, I really want to thank you for joining us today. You are truly a pioneer and an expert in this space, and we truly appreciate you taking the time to spend it with us today to
yeah,
explain.
thank you very much. I hope they can see these
Yes.
links in this
Yes.
screens
Yes.
that I'm sharing.
No, no,
Okay.
no. We already placed them in the chat of the live
Okay.
stream, so they can just click directly on them. We want to
Okay.
make it as easy as possible.
Yeah.
And so for those of you out there and in the interwebs, if you didn't get a chance to send us your questions, please feel free to send us a note at conversations@mcw.edu. And I hope you all join us next month for a virtual coffee break with a scientist. Thank you. Have a good
Thank
day.
you.